Hello everyone, and welcome to this webinar hosted by the National Collaborating Center for Healthy Public Policy, or NCCHPP, titled Public Health Systems Governance, Better Understanding and Acting on Governance to Strengthen Public Health Systems in Canada. My name is Olivier Bellefleur, and I am the scientific lead for the NCCHPP. I'll be co-facilitating this webinar today with the help of Caroline Cambourieux, an expert scientific advisor working at the center. We are also joined today by Mylène Maguire, our communication officer, who is responsible for the technical and logistical support. We have the pleasure today of being joined by three renowned speakers. Our first speaker will be Erika de Ruggiero, who is an associate professor of global health at the Dalla School of Public Health, University of Toronto. She is the director of the Center for Global Health and the co-director of the WHO Collaborating Center on Health Promotion. Our second speaker is David Hunter, an emeritus professor at Newcastle University in the Population Health Sciences Institute. He is also a visiting professor at the University of Chester, a special advisor to the WHO Europe on Health System Transformation, and a member of the WHO's Global Network on Long-Term Care. Lastly, but not the least, we are joined by Jean-Louis Denis, who is a full professor in health policy and management at the University of Montreal School of Public Health, a researcher on innovation and health system at the Centre de Recherche du CHUM, and a research fellow in residence at the Centre de Recherche en Droit Public. He also holds the Canada Research Chair on Design and Adaptation of Health Systems. I want to thank them for accepting our invitation to speak during this webinar. Before we get started, there are a few technical information I have to go over. First of all, the microphones and cameras of participants are off, since there are many people in this webinar. To ask questions to our panelists, we'll ask you to use the Q&A function, which will also allow you to vote for questions you would like us to prioritize during the panel. You can also use the chat function if you want to share comments or resources with all the participants. To do that, don't forget to select the Send to Everyone as shown on the slide. I also want to mention that this webinar is being recorded and that the recording will be made available on the NCCHPP website in the next few days. To begin, I'll just say a few words on the National Collaborating Centers for Public Health program of the Public Health Agency of Canada. It finances 6 national collaborating centers on key areas of public health, which are hosted by different organizations across Canada. The NCCHPP, for its part, is hosted by the Institut National de Santé Publique du Québec in Montreal. The mandate of the NCCHPP is to support public health actors in their efforts to develop and promote healthy public policies. And governance of public health systems, as we'll see, has an important role to play in that regard. On the slide, you can also see our main active projects. Since the NCCHPP is located in Montreal, we want to acknowledge that we are on an age-old Indigenous territory, a place of meeting and diplomacy between peoples, and the site of the signing of the Great Peace Treaty. We thank the Kenyan Kenaga Nation for their hospitality on this unceded territory. This slide presents an outline of the webinar. Following my introduction to set the context, Erika de Ruggiero will present key findings from her report on public health systems governance in Canada. On the slide, you can see a word cloud made from her report, which shows some of the key themes that will be covered in this webinar. Our presentation will be followed by the interventions of David Hunter and Jean-Louis Denis, who both have contributed case studies for the report. The rest of the webinar will take the format of a panel with our 3 experts, wherein we'll ask them to respond to some of the questions you proposed when you registered and to some of the questions you'll put forward in the Q&A during the webinar. So please don't hesitate to submit them as they come to mind. To give all of you an idea of who's in the webinar with us today, I'll just say that we had over 500 registrations for this webinar. So clearly there's an interest in the topic. Most of you, as you can see, come from Canada, and we have a very good representation from across the country and from different organizations. I take the opportunity to welcome all of you and to thank you for joining us. When you registered, we ask you if your work requires you to have knowledge of public health systems governance, and as you can see, most of you do. We also ask you how confident you were in your ability to understand public health systems governance, and the majority indicated somewhat confident, and almost a quarter responded very confident. We thus have with us today people who are interested and who are knowledgeable about public health systems governance. So I think the conversation should be very, very interesting. To provide a bit of context, I'll just mention that this webinar is organized in the wake of the last CPHO report titled A Vision to Transform Canada's Public Health System. In her report, Dr. Tam invites us to reflect and exchange on the lessons to learn from the pandemic to strengthen our public health systems. This webinar is intended as a modest contribution to that invitation. To inform our report, the Office of the CPHO commissioned 4 reports to independent experts that the National Collaborating Centers for Public Health decided to edit and publish to make them broadly available. There's 1 report on First Nations, Métis, and Inuit visions for public health, 1 report on a public health data system for Canada, 1 report on strengthening community connections, and 1 report on public health systems governance. This webinar is about this last report, which was directed by Erika de Ruggiero. So without further ado, I'll pass the microphone to Erika.
Thank you so much, Olivier, for that kind introduction, and welcome to everyone. It's really my pleasure to give you a brief overview of some of the key highlights from the report, which I encourage you to have a close look at. And I just want to thank the NCC Healthy Public Policy for hosting this webinar, and to my co-presenters, David Hunter and Jean-Louis Denis, for participating in this. We really look forward to your questions. So I'm going to start off with a presentation that will just give you sort of an overview of the report. Just to situate the discussion a little bit, I will start off by what this report aimed to achieve. So as Olivier mentioned, this was one of 4 reports that Theresa Tam's office commissioned to support her last annual report to Canadians on the future of the public health system or systems in Canada. And so the objective for this report on governance was to really look at what are the realistic opportunities for strengthening, improving, and transforming existing public health governance in Canada. And there were several research questions, and they addressed, for example, what are key elements and attributes that are needed to support key areas of public health governance? What are examples of successful public health governance models or systems or approaches? And then how can governance play a key role in achieving equity in health, and what is its relationship to equity in health? So just to give you a sense of what the ambit for this report was, these were the rather bold but important objectives and research questions that we were asked to address. So certainly from our review of the literature and the case studies that I invited colleagues such as David and Jean-Louis to help produce, along with another case study by Carole Clavier on intersectoral action, became very clear that governance is one of these topics that can mean everything and nothing at the same time. And so what we really tried to achieve in this report was an ability to unpack what I'll call the black box of governance, which sometimes ends up being used as a bit of a container, and to describe a number of different things. So in doing so, we went to the literature to try to understand what is governance with a perspective on public health. So I think for those of you who know what governance means, you know, it's been defined in many different ways, but one of the ways in which it's been defined is that it's the sum of the many ways individuals and institutions, public, private, nonprofit, manage their common affairs. But the question of what's in common, or what are common goods, or what are mutually agreed upon goals is not a trivial point. When you think about governance in the context of public health, the attempts of governments and other actors to steer communities, whole countries, or even groups of countries in the pursuit of health as integral to well-being through both whole of government and whole of society approaches. So that's sort of the operating definitions that we proposed in the report. But it became very clear that health is unquestionably probably one of the most densely populated areas, as I say in the report, of governance globally, which I think poses a number of challenges for good governance and what we mean by governance and what are effective models of governance. So in helping to frame our report, we selected a framework that was published by Carlson et al. About 7 years ago, that was applied to public health, that started to delineate what do we mean by governance. And he and his co-authors identify 6 functions. These include policy development, legal authority, so the use of acts, legislation, oversight, so which organizations are responsible for and accountable for oversight of public health, resource stewardship, so that speaks to what kind of financing models are in place for ensuring a stable and durable base or investment base for public health. Partner engagement, because governance of public health involves many actors within and outside the health sector. And so partner engagement is another key function of governance. And finally, continuous improvement, which really speaks to research and evaluation. And I'll come back to each of these in a moment. So these were sort of the 6 governance functions, and the report is organized according to some of those. So what does good governance mean? And I think this would be a really important question for us to have as we reform public health systems going forward in Canada. But based on our review, some of the key principles that we called out really speak to the fact that governance structures actually can play an important role in reinforcing equity, or conversely, reinforcing epistemic injustices and structural oppression. And so principles such as equity-driven, an anti-colonial approach, which I think speaks to the important role of self-governance by Indigenous peoples. And I would encourage you to have also a look at my colleague Margot Greenwood's other report. This was one of the other 4 reports. Because we do address to some extent Indigenous governance issues, but in the context of this report. But I would invite you to also look at her report that was commissioned. The other key principles include transparent and accountable deliberation and decision-making. The other concept that really emerged as being very important is to govern for resilience. And really resilience is understood as the capacity of a system to absorb, adapt, or transform in order to maintain essential functions when faced with shocks and stresses like the pandemic currently highlights. But there are many other forms of shocks that governance needs to be responding to. Persisting inequities that certainly predated the pandemic. The other sort of feature of good governance is competent leadership, and leadership and governance are very much linked. And one of the key things that we highlight in the report is that governance structures should be developed and assessed through the lens of organizational learning. And who does that learning? What are the role of leaders, and how do organizations lead? is a really important, I think, component of good governance, so that competent leadership. And finally, this notion of capacity. And so the report talks about different forms of capacity. I've only highlighted one here on the slide. But paying attention to not just structural capacity, that means decision-making and accountability mechanisms among public health organizations, but we also speak about mandated capacity. So that's really the authority of decision-making responsibilities for public health agencies. There's also personal capacity that really speaks to the competent and skills of public health staff responsible for governance. So there are many ways to think about capacities in a nuanced way when we think about good governance. So the Public Health Agency of Canada, when they asked us to pull together this report, asked us for what is the most effective model. And this was actually a very challenging question to answer. And really, there are too many models that are operating, and that's probably all right. However, part of the reason for that is that public health, at least in Canada and certainly in other countries, as we'll hear in a moment from David Hunter is really governed at multiple levels. And the role of those different levels varies depending on the type of nation state we have. But here in Canada, we have federal, provincial, territorial, regional, local roles. We also have self-governance by Indigenous peoples. And so we have different ways in which governance models need to operate given the different levels at these different system levels. But we also need to think about governance of the what is being governed, which is public health, which leads me to my next slide, which is what is being governed, which is not a trivial point. And so in the report, we really try to think in a more nuanced way about governance for public health. So those are the many different actors that make up the different public health systems in Canada. And often when we think about what is being governed, part of that speaks to, well, how is public health being even defined? We use public health functions such as health promotion, surveillance, health protection, emergency preparedness as ways to define public health. But that doesn't necessarily communicate a vision or objectives and priorities for public health, which then presents some challenges for answering the question, what is being governed in public health? The other way to think about governance, and we make this distinction in the report, is that public health, in order to really address the upstream structural drivers and determinants of health and health equity, need to be working in tandem with other sectors outside of health. So education, housing, other sectors that have the levers that can influence health. But that poses a number of challenges in terms of what is being governed and who has responsibility and authority. So as you can probably imagine, governance can play a number of different roles. One of the things that we wanted to draw attention to is this concept of values management. So is public health actually being valued? How is it being valued? And this can in turn be influenced by political, social, and organizational contexts. So is public health considered a common good? Will impact actually whether it is valued, whether it's invested in. And so we speak a bit about that dimension of governance in the report. The section is relationships management. And so here, an important role of governance, and it really does vary on the different kinds of models and structures and what they aim to achieve, include information sharing. So this is, I think, a fairly passive way to think about governance, where, as that suggests, information is shared among different actors who are participating to achieve an end. Cooperation starts to really get more at the interaction between sectors. There's some loss of autonomy between sectors. Coordination really results, I think, from enhanced efficiency and effectiveness, shared financing, greater codependence, again, greater loss of autonomy. And then finally, integration. This is where we see multi-sectoral political processes that really are shaped not just by one sector, but multiple sectors. So depending on who's involved in the role of governance, there are different ways in which relationships need to manage and with different ends. So just finally, I want to sort of move to some of the key results. So as I mentioned before, we found that there was no one preferred approach to or model for public health governance. And you know, I think this is warranted given the complexity of public health and the diversity of stakeholders that need to be engaged. And so governance models that we found were primarily classified as either hierarchical or collaborative. And I think as you get more into working intersectorally, you tend to move more towards a network model of governance where there's more shared decision making rather than more centralized sort of top-down functions where you see a hierarchical governance structure, which we sometimes see in certain nation states, which I'm sure we'll hear about more from our colleagues. The other thing that was, I think, rather challenging for us to find just one model of governance is that, at least in the Canadian context, and this may be true certainly in other countries, we really lack a systems approach to public health. We really have multiple systems. And so this, of course, poses huge challenges for not just the governance of public health, but also for developing foresight and search capacity to really be able to govern and function as a strategic, cohesive, and equitable public health system. And then finally, there is really a limited evidence base. I know this may sound very obvious coming from an academic, but truly there is a lack of evidence base available on effective models for public health, not just in Canada, but more generally. The literature that we reviewed a lot was very useful, very conceptual, but this is why the report really calls for greater attention in national public health systems and services research funding to pay attention to the focus of governance models and to also create the kind of incentives for embedding academics within public health systems and to be able to create that co-production of knowledge to be able to better understand in situ governance and other models for decision making. So the report ends with a number of recommended actions, and what is listed in brackets are the key functions that I outlined at the outset as a way of organizing our recommendations. So the recommended actions include, first of all, the need for a pan-Canadian equity-driven strategy, including a clear vision, objectives, and priorities. As I mentioned, what is being governed is really quite important, and an expert panel. And so this, we do give examples of existing expert panels in Canada, but also models from other countries, such as the National Academy of Medicine, that could periodically help to create priorities so that a set of priorities for public health are agreed upon. And of course, these would need to be discussed between federal, provincial, and territorial players. The second speaks to leveraging the federal spending power to promote greater support and collaboration across public health infrastructures. So one idea we propose is a form of innovation fund that helps to incentivize public health system strengthening. And this is not a brand new idea. Echoes of it were somewhat mentioned even as far back as the Naylor report following SARS-1. And so this would be an example of an investment strategy totally dedicated to public health system strengthening. The third relates to the development of a separate act for health and well-being, or a public health act. And so this would be an example of legal authority. I didn't have time to get into the whole section in the report that talks about different ways in which we can think about using legislative levers to help incentivize and attention on public health. So this act would help to define a clear scope that emphasizes population level policy and program interventions that really facilitates a health in all approach. Some may argue, well, why not just open up the Canada Health Act and include a public health component? But there were some concerns raised about the fact that there are many other healthcare issues that are also of critical importance. We're talking about some of them right now, like pharmacare and oral health care. Would public health get sufficient attention if we did not actually have its own dedicated act? This is not an insurmountable, this is a very challenging, I think, recommendation, but one that perhaps we need to pay attention to given the current context. The other action relates to strengthening governance mechanisms for intersectoral action, because if we're truly going to impact on population health and health equity, we need to be intervening on the upstream determinants, social and ecological determinants of health. And so this really requires support for governance mechanisms for intersectoral action, which can happen at all levels, not just at the local level. And so this could be something that the Public Health Agency of Canada considers in terms of really linking, and there is this work already underway, but more formalizing government department linkages that work intersectorally on major issues. The next really relates to partnership engagement, which I think goes without saying. And so the need for formal and informal engagement processes and bodies to really respond to different threats. And then finally, to establish and resource a national public health systems and service research agenda that explicitly looks at a focus on governance. So this relates to the function of governance called continuous improvement. And so an example would be to assess the effectiveness of different governance structures for public health. Anytime there are structural changes in the public health system, we don't always have a very good evidence base upon which those are made. And so we need an ongoing program of research that really studies in situ these different structural changes that are occurring to governance structures within our own country at multiple levels. And this really needs to be informed by the best available evidence. So that in a nutshell is just a brief snapshot of the report. There's certainly more I could say, but I'll leave it there and I'll turn things over to my colleagues to make some additional remarks, and we'll look forward to your questions. Thanks so much for listening. So I think, David, I'll turn things over to you to kick these off. Thanks so much for joining us.
No, pleasure. Thanks, Erica. And thanks very much for inviting me to take part in this interesting session. I've got a few minutes, I think around about 5 to 8 minutes. So let me just pick up a couple of key points from the English experience that builds on what Erica has been saying. We're in the midst of another public health reorganisation in England because in its wisdom, the government last year decided to get rid of the national body that had been operating since 2012, Public Health England, in the midst of the pandemic on the grounds that the pandemic had revealed weaknesses in the way Public Health England had been performing. So rather than address those weaknesses within Public Health England, the government decided to replace it with 2 new bodies that are presently being set up and are finding their feet. So that's an interesting issue in terms of governance, that a government could suddenly, unexpectedly, with no consultation, simply abolish a body that had been in being since 2012 until last year, so almost 2 years, almost 10 years. Governance is complex in England, but it is elsewhere too, as Erica said, because having the national body operating nationally in government, quite close to government, I'll come back to that as my second key point, but then working down to the local level through regions, and then working into local authorities, elected local authorities, where public health locally has been organised since 2012. Previously, it was part of the health service, and public health was taken away from the health service and put into local government in 2012 on the grounds that public health, it made more sense in terms of a whole system's approach to public health, in terms of tackling health improvement, health inequalities, for public health to be located in local government rather than the healthcare system. And that worked reasonably well, but Public Health England nationally had no authority to challenge what local government was doing. So if local authorities were varying the way they spent the money or not addressing priorities in relation to public health, there was no stick with which Public Health England could bring them into line. It was very much a relationship that was involving no policing function, just providing local government with evidence, with knowledge, with insights into how things could be improved in public health, but not really, other than providing tools and data, not really being a policeman of that system. So it was a bit messy in terms of how things were actually functioning. But the one good thing about public health England was it brought the whole public health function together, all the three elements. There are three domains in public health: health improvement, health protection, health service improvement. And these functions were all brought together in one body. Now, to replace Public Health England, the government's moved away from that integrated approach and has separated public health from having a dual mission to protect and improve health, to having agencies responsible for each of those functions. So there's a new body called the UK Health Security Agency that will tackle health protection, and another body, Office for Health Improvement Disparities, bit of a mouthful, that will look at the wider public health issues. And these bodies will be governed quite differently. They'll be organized differently. They'll have relationships with government that are slightly different. So the governance structure is now becoming much more fragmented potentially and much more complex. That raises an issue, the second issue I'll just touch on briefly, which is the degree of independence from government that a public health body should have. There are conflicting views about this. There are some who argue that if public health is going to influence government and influence policy and influence politicians, it needs to be closely involved in government in order to play that role. There are others who say that makes it difficult to speak truth to power, and that to be able to do that, public health bodies need to be independent from government, and there needs to be some sort of arm's length relationship. If the relationship is too close, they get sucked into government and get silenced, if you like, if they try and be controversial and try and speak truth to power. But if they are too far away from government, then the opportunity to influence policy becomes much more restricted. And these debates have raged over the last few years in relation to what degree of independence or what degree of being part of the government makes optimal working practices. And I think for most observers, not all, but for many, the feeling was that Public Health England lacked independence and lacked a voice that it was able to use to put pressure on government to do things differently, or to call it out if it wasn't responding appropriately in terms of delivering its own commitments. So I think these issues are quite important in relation to how governance operates in a political context. So my last point is simply that governance operates horizontally and vertically across government at different levels, both between and across levels of government. And I don't think public health has successfully managed to adopt that whole systems perspective in relation to how things are managed across different government departments that all have an influence and an impact on health in the widest sense. Too often public health bodies get locked into the health departments and fail to embrace the other departments that make up government, many of which are arguably much more significant and important, particularly bodies like the Treasury or finance departments. So that would be more my takeaway messages. The governance is incredibly complicated. It's ever changing. There are risks to how you organize public health if you want to integrate or avoid fragmentation, and the degree to which you want to maintain independence from government as opposed to being too close to government, and what is the optimal relationship in terms of that structure. And in England's case, we're still wrestling with these issues. Thanks very much. I'll leave it there.
So I guess it's my turn. So thanks for the invitation, and I will build on some work that we did in the context of doing the case study for this report, but also different works and assignment around the broader theme of so-called health system reforms. And building on what David said, I think when we talk about governance of public health, and I will take what is called on our side of the Atlantic, the institutional dimension of public health. And within the institutional dimension, we have two very different aspects, in my view, that must work in synergy. One is the system of service and organization within a given jurisdiction and across jurisdiction that deliver, let's call it, public health services or intervention. So kind of network of agency, professional, and so on. And another level of institutionalization, which was very well described by David, it's this idea that you have to institutionalize public health within government. And this is a delicate operation because you strive for strength, influence, and independence at the same time. And surely there was a lot of debate in Quebec, and I think in some other province, about this managing this interface between so-called political interests and power and independence of public health. We debate a lot of this in Quebec, including with the Quebec Association of Public Health, and with Dr. Rochon also, and as you know, he passed away last fall. And one of the options was this idea of creating a kind, in quotation, of treasury board within government, but for public health, like a kind of authority that can really work toward this notion of health in all policy, and that can really influence policy choice across government. And I think this is still an issue in many jurisdictions. And Carol last week, based on Australia, gave example of potential option. But the issue here is really, can we make policy to generate what is called in the report equity and societal health? And can we have this well located and positioned within government? Looking at the report and all the conversation around governance, and again, it was in the conclusion of David, governance is a complicated subject. And I guess the growing interest for governing so-called public health system relate to a kind of an observation that there is a deficit in institutional innovation or in governance to govern public health for high impact, I mean, here for high population health impact. And this can be observed in the definition of target, objective, the kind of policy we put in place, the relationship among different levels of governance, but also between the so-called public health system, the institutional basis, and what is called in the report, the relation between a nation state and society. I think this need to be much more developed than it is from within public health system, and tools and knowledge to, I think, what we observed during the pandemic, but we have observed this in other situations too, is the use and availability of data to govern health in society for equity. And there was a paper in the Canadian Journal of Public Health on this issue that underlined generally in Canada the data to look at health equity issue are generally very poor or unavailable. And this is just one example. And another aspect also is the kind of culture that health system bring at the forefront. And if we look at the allocation of resources across provincial jurisdiction, for example, in Canada, through the years, like it's much more easy to allocate resources for care than to allocate resources to support the development of the health of the population. And everyone knows that this is not just a business of the so-called healthcare system, but it is clear that it is very difficult to rebalance allocation of resources within government in favor of high impact population and perspective. And this is somewhat related to my second point on the institutionalization and of a public health authority within government. Another aspect is I will see the illusion, but I guess it's not weighted uniformly across provincial jurisdiction and territory in Canada and across comparable jurisdiction internationally. But there is a difference between having on paper legislation, rules, policy, what I call often very high potential policy instrument in design, or even when it is adopted, not just in design, and the real activation within a given society of these instruments, and the capacity within government to activate these instruments. And this was one of our conclusions on the Quebec case study, and we're probably not alone here, is that very often when you look at paper, you can see we have a lot of instruments to make things happen in terms of population health and equity, but we have low resources and capacity to activate at large scale. So just as a conclusion, what I call governing public health system, if we can speak in terms of post-pandemic period, I'm not sure, but let's call it that way. I think one of the venues to strengthen the governance of public health system is first being clearer on the importance of each function of public health and the relations and interaction across these functions. For example, between surveillance and monitoring of the health of a population and another function, which is intervention to reduce health equity, for example, or policy intervention. I think there is a risk in the post-pandemic period to somewhat over-focus on surveillance and monitoring as being the core predominant function of public health system. Another aspect that I mentioned is going beyond legislative structuration of the field of public health and paying a lot of attention on implementation capacity and activation of high impact policy. Another aspect also is it's related to the relationship, and this was, I think, partly when David talked about independence. It's about the relationship between the system of agency services, government unit in public health, and science and civil society. And I think the interface between a broader scientific community and public health system need to be looked at, and independent science research group and so on should be considered as capacity to support public health intervention too, even if they are independent. Then the classical case when we talk about health system and public health is the place of measure and accountability, and how we move from measure accountability to learning and adapting intervention. And I will close on comments on public health system leadership, and as Erika mentioned, leadership and governance goes end to end. And I think the question of plural leadership would gain in importance in various sectors of the economy or activities, can be a way to think also about leadership of public health system, like bringing more input from, as an example, from social and human science. And there is a count within our network of public health agency, there is a count to have more capacity in this regard. And in my view, to have more capacity, you need to embed some of these capacity in the leadership of public health system. And it's still not the case in most jurisdictions that I know. So I will stop there by saying that we don't need necessarily restructuration on the ground, but we need to take seriously, in my view, these various points to strengthen the governance of public health system. Thank you.
Well, thank you very much, Jean-Louis, David, and Erika, for sharing your thoughts with us today. I noted a few common themes that came across, I think, your presentation, and that's just a very a selection of what you've been saying. But there's the question of maintaining or reorganizing the core public health functions. That seems to be a current theme. The question of striking the right balance between independence and internal influence that the public health system can have with central government. There's the question of the right balance also between centralization and decentralization of the system itself. The question of the importance for intersectoral governance for healthy public policy. And as Jean-Louis framed it, the question of having the capacity to activate the numerous policy instruments that we may already have. I would like to go to Caroline to see if there was questions in the Q&A, or if we want to start with questions that were submitted to us when you registered, to leave people the time to either write our questions or to vote for some questions. So Caroline, do you have a question for us?
Yes, I have a question. We received many questions in the Q&A. The first question is related to a select results slide that Erika presented. And the person would like to know if it's possible to provide some examples of actors challenging PH governance.
So Erika?
Yes, sure. So, I mean, there's so many. I'll just pick one that I think suggests that for me, public health has to be more than about protection and infectious disease. It has to be about the social and ecological determinants of health and health equity. So if you take that point at face value and agree with me, that means you have to be working with sectors outside of health. However, the further you go away from that, and with some exceptions, there are legislative instruments that give public health some jurisdiction in those other sectors to have a say about the health impact of those other sectors. But for the most part, that's not true. And so that means you do actually have to use a lot of what I didn't get a chance to say in my presentation, but in the report, more soft governance approaches. So, you know, which is persuasion. And that's where governance structures that are really based on shared ideas, where you actually work towards that integration that I've described, rather than just sharing information, which really doesn't get you far, and share resources, that you can really make a difference on those upstream determinants of health. But that's very challenging because public health is also often on the hook, in Canada at least, at many levels, for just delivering on what it's in their standards. And the more further away they get from that, the less resources they have. They barely have enough resources to be able to deliver on what's in the box. And so I think that's the other thing that challenges them, is the resource base within which they're working, to be able to work with many different other sectors. There are a lot of interaction costs. I'll leave it there.
Thank you, Erika. So, Caroline, do you have another question for our panelists?
Yes, quite different question. Who should have or current has responsibility for driving changes and improvements to public health governance in Canada?
Maybe we can go to Jean-Louis for that question.
I guess this question has two meanings, depends where you stand for. As you know, the role of the national and federal level is often controversial in Canada. But I will say that it's probably a balancing act. I think if we take the case of health system in Canada and then policy, and it will be probably the same for public health system, like ambitious and bold policy idea from the federal government can help a lot, but they need to adopt this kind of policy, like relate to equity. I always thought that the federal government is well positioned to think about a kind of Canadian Council on equity, and it's part of Erika report that reinforced this. But I think that that's a responsibility that they can take, and through some reshaping of the Pan-Canadian organization, as an example. Then I think province and the different level of governance within each province, and as you know, we have different models in Canada, and I guess there is a question here where public health should stand in province that create this kind of single health authority to govern the health system, like the Ontario Health Agency, Alberta Health Services, and so on. I think there is an issue here on how to configure public health governance to have a bigger impact in this context would be a question for me. And I still think that municipality is a very nice level to do high impact stuff in public health, but I stop there.
Thank you, Jean-Louis. I would risk a follow-up question using one of the questions in the Q&A and I would address it to Erika, because I know she talks about it in her reports. It's about the FPT tables in Canada that tends to, according to one of the questions, pay lip service to collaboration and have difficulties of working together. So I was wondering if you have any take or recommendations about how to go forward with the recommendation that you highlighted in your report that touch both the federal but also the provincial and territorial governments to work together regarding public health?
Yeah, another big question. So two quick points. One is there aren't a shortage of structures, FPT structures, and I think that's part of the problem. So where is decision making actually happening? So there's the semblance of many tables, and in a different project I worked on with other colleagues around science being solicited during COVID, we just keep adding structures. But that doesn't necessarily mean effectiveness. And I know there were plans before the pandemic hit to evaluate the FPT structures. They've gone through a couple. So we have the Public Health Network Council, we have CCMOH, the Council of Chief Medical Officers of Health. We have the whole public health network that includes 3 committees. Why I know this all off by heart, I don't know, and there are more and more. And my point is, where is decision-making actually really happening? Or is there a semblance that we are engaging? And there are structures, though, that were created for emergencies, like they're called the SAC, which were mobilized during COVID and previously for the opioid crisis, which seemed to have been effective. The real answer to the question is, do we really know? Because we're not evaluating them, and they were actually going to be. And so I think more is not better. And there is probably a need to better understand what those things do. And maybe it's just information sharing, which is fine, but are there other ways to do that? So I'm not suggesting that they don't have a purpose, but let's not pretend they're governing, right, in the true sense of the word. I'll leave it at that.
Thank you, Erica, for trying on a very, very difficult and complex question. And thanks all panelists for that. Caroline, do we have another question?
Yes, there is another one. What would you recommend to a health minister that intended to rebuild la santé, de rebâtir la santé, to rebuild the health by reforming public health authorities to ensure independence, transparency, efficiency, and consistency? What would you recommend?
Thank you, Caroline. I would tend to go first to David to have an external view on our systems, if you don't mind, David, sharing your thoughts with us.
No, that's an interesting question. It's like the elevator question where you have 2 minutes with the minister to convince them of something that needs to be done differently. I think if the minister is determined to have a mature, functioning, independent system, then there are things that can be done, and there are mechanisms that can be put in place to ensure that degree of independence. I think one is system leadership. We've talked about leadership, but leadership style, I think, is quite important here. And I think having system leadership, having an organization led not structurally, but led culturally by people who can embrace the system and work at different levels, horizontally and vertically. I think to be independent is fine, but you have to have a purpose as to what that independence is for. And I think being independent on its own is insufficient. You have to have people who are skilled in terms of networking, in terms of being able to work across different boundaries professionally and organizationally. And you have the soft skills that Erica mentioned earlier in relation to that. And I'm not sure we develop public health people in those skills sufficiently. We develop the technical skills in them, but maybe not the softer skills in terms of how to make things happen in government, whether it's local government or regional or national. So I would put a big emphasis on system leadership and developing what one in the literature calls boundary spanning skills, people who can work across boundaries. Not everyone's comfortable at that. Some people like to be at the core of their organization, but other people like being at the edges of their organization and working across those boundaries with others. And I think in public health, we need to develop a cadre of people who are capable of doing that. So it's not just capacity, it's also capability in terms of those skill sets. So to achieve those issues that the questioner raised, I think I would put an emphasis on system leadership. I would see public health as an integrated whole, and I would put the stress on developing capacities and skills to enable people to work in different silos and across those silos. There's more that one could say, but I'll leave it there.
Thank you very much. That's very, very useful, and it touches on many aspects. I would add probably to the mandate also that Erika was mentioning, of having the mandate and the resources to do this boundary spanning that is usually hard to find resources to do, but you're adding the very important idea of developing those soft skills and the capacity of the organizations to do that. I'm wondering, Jean-Louis, did you want to comment also on this question regarding what you would say to a minister who would be looking at reforming public health systems? Oh, your microphone is off, Jean-Louis. Perhaps we'll go to another question while you figure this one out. So, Caroline, do we have another question?
Yes, there's another question. And how can we come up with systematic and better ways of assessing the effectiveness of the effectiveness? And the person suggests using mixed method and surely going beyond mere impact evaluation, but what else?
Another great question. I would direct it first to Erika, if you want to jump in.
Sure. Yeah, so thanks for the question. I actually think, I mean, of course, it depends on what question you want to answer, but I think one area that is perhaps underutilized is case studies, once it does allow for, and I'm not just saying that because I asked my esteemed colleagues to produce them for this report, but all joking aside, I think what case studies really help you do are a couple of things: draw on multiple lines of evidence. They also allow you to present something in context, and I can't emphasize more the importance of context and the changing context. And this is something we don't do a very good job of always in public health. We tend to strip away the context that's changing in how we describe. Some disciplines do that much better than others and value context rather than control for it. And I think you really need a rich description of the socio-political context. And so I think, not to say one method is the best, but I do think case studies are one way to do that. But we do need to be investing in research on an ongoing basis, not just a flash in the pan. And I know my colleagues won't say this, or maybe they will, but I'll say it for them that, given their disciplinary background, so we need management, political science, working with public health and other disciplines to really better understand case governance in its own, institutional, organizational, et cetera, context. So that's a multi-discipline, multi-method, routine, ongoing, I think, effort. And the other final thing I'll say is we fund a lot of, I think, more healthcare research, which is very important. I don't mean to take away from that, but we're talking about a different kind of orientation when we're talking about public health. And I don't need to define that for everyone on this call, hopefully. But I do think that governance that's oriented to public health as opposed to healthcare has some particular challenges and issues to contend with. And so research needs to line up with that orientation. So, and part of, as I, remember one of my colleagues saying to me many years ago, especially within the context of a patient-provider encounter, the relationship is not necessarily easy, but it's much more defined. When you're talking about public health and its need to manage relationships, and as David nicely put it, boundary span, that requires a number of different skills, but also means complexity around the how you study that, right? And so it's a bit of a different animal.
Thank you, Erika. I wanted to loop back to Jean-Louis if you wanted to comment on the previous question or on this question regarding
well, I think both
evidence.
can go together, and it will be a footnote on these two excellent reply, and apologize, my micro froze without understanding why. So I guess one of the issue is we always underline that we have insufficient resources allocated to public health in the broadest sense of the term. But I think thinking about new investment in resources with a focus on capacity and capabilities, the way it was discussed, is very important. Just replicating what we have with more resources, I think, would be insufficient to have high impact. The second aspect is in system leadership, you have this notion of how to try to make efficient and productive so-called multi-level governance. The kind of communication between these levels and collaborative governance between these levels while having accountability at the same time. And it can be multi-vertical and horizontality too when we think about intersectoral and intervention or activities. So that would be the two things that I would add to the previous comments.
Thank you, Jean-Louis. I would tend to add to go to David also for this, I think, really quite central question that was also raised in the report that Erika directed, the idea of the lack of evidence and what kind of evidence do we need to go to a learning system in public health. So I was wondering, from your perspective from England, what can you share with us?
Well, I think people are struggling with exactly those sorts of issues. I mean, in some areas we don't lack evidence. What we lack is implementation of the evidence and the application of the evidence to policy. So I'm always wary about stockpiling evidence where we often have evidence that we're not using, and we might want to research why we're not using the evidence as opposed to stockpiling more evidence. But there are gaps. And I think the way to tackle them in public health is to adopt the kind of PDSA approach, Plan, Do, Study, Act. We don't have all the answers. We don't have all the evidence up front. Some of the evidence has to be gained by doing. Learning by doing. And my view is that in many cases, we should be testing, trying things, experimenting, making sure we build in the evaluation while we're doing that, using a mixed methods approach or whatever method we want, but making sure we bring in those different disciplines that Erika talked about, and I would add anthropology to the list. Too much evidence seems to come from health economists, which is fine. I have nothing against health economists, but I do think that often they dominate the research agenda in public health in a way that's not necessarily always helpful or insightful. But if we adopted a PDSA framework, that would allow managers and practitioners and policymakers to experiment and trial things and do things differently and learn as we go, as we develop, rather than developing managers who come into an organization and think they know the answers when they clearly don't. So we need to get a much more sophisticated relationship between people who are doing, who are managing, who are implementing, but who also need to access the evidence as they go to inform their operational activities. And we don't do that. We have these things going on in separate camps. Academics do research and managers do and manage. And we need to break those boundaries down, I think. And academics have a lot to answer for too, because often they make their work inaccessible, jargon-ridden, not framed in a way that can engage with policymakers. So again, if we adopted a PDSA framework, that would, I think, open up those discussions to a much more rich set of encounters.
Thank you, David, for your perspective on this important issue. While preparing for this webinar, we saw one question that was submitted during the registration that we thought would be a good question to end this panel. So I would go to Caroline to to ask that question.
That's the final question and a very interesting one. What do you think of the future of public health will look like in 5 years? So what do you think?
I would start maybe with Jean-Louis, go to David, and then last to Erica.
Well, it would be a very clear answer. I don't know. It depends. And this is the usual answer from a researcher. I think there is a real window of opportunity now to take the different aspects that were discussed in this webinar and to take some time to think about the implication for the public health system community, for researcher, for citizen, and so on. So there is a real moment to take, and if it's not taken, I think we will have minor adjustment from the current situation.
Thank you, Jean-Louis. David.
Yes, well, I agree with all that. I hope that in 5 years' time, we've learned the lessons from COVID, because COVID has revealed an awful lot about the gaps and deficiencies in our public health systems, as well as some of the good, positive aspects as well, and issues around resourcing. But for me, a big lesson is the link between health protection and infection control and inequalities and poverty. COVID has shone a stark spotlight in most countries on the growing inequalities that exist, and the link between those and health protection. And for me, to separate health protection from the promotion of health improvement, I think would be a big mistake. And that's, I think, a problem we are now facing in England, because the risk is that we then put all the money into health protection. That's the sexy public sector. The public view would be that the money needs to go into health protection and infection control, and don't worry about inequalities and poverty and so on. And that would be a huge error, in my view, a catastrophic error. And we're in danger, I think, of making that in England. So in 5 years' time, I would hope that we can see public health as a truly integrated system, where we've learned the lessons from COVID in terms of what has to happen locally, but also what has to happen across the whole public health function.
Thank you, David. And Erica, last word on this question.
Yeah, well, I mean, it's hard to top those last two responses. I think they're excellent. I do really would echo the we need to learn from our lessons. We didn't learn the lessons from SARS. Actually, some of the recommendations that I echo in the report on governance are from SARS-1. They're unfinished business. And so I think we have a moral responsibility to do better and to learn from our own mistakes. And we have a lot of lessons we can learn, not just from our own country's response, but the global response to this pandemic and the many inequities that are still existing. The second I would say is that we need to use governance structures more strategically. We need to have surge capacity in our governance structures. We have some good examples of where that's worked, but that means having foresight, the right kind of evidence, not necessarily more, but the right kind of evidence. And finally, in the context in which we live today, and given the many past egregiances, I would end on not just equity, but I think governance has to do a better job of addressing and dismantling systems of oppression that reinforce those inequities. And the way in which we build our governance structures have to attend to reparation with Indigenous peoples in Canada and many other groups who continue to be marginalized, and that predates the pandemic. And so that's not new. It's been further exacerbated. And so those are, I think, ways in which governance can do better for people. And I'll leave it there. Thank you.
Well, thank you. Thank you to our three panelists. Really appreciate your contribution to this webinar. It's been very rich, and I want to thank also the participants for staying with us. For those who are interested in this topic, I invite you to read the reports we talked about and to go on the websites of the 6 national collaborating centers who are also offering activities on related topic. For our part at the NCCHPP, we'll be hosting webinars this spring on other aspects of the public health systems in Canada, including their centralization and decentralization and their financing. So 2 aspects that we touched on today. So I invite you to subscribe to our e-bulletin if you want to stay informed of our next activities. We will also be sending you a link to a short evaluation for this webinar. Please take the time to respond. We really use your feedbacks to inform our work. And finally, thanks again, everyone, and I wish you all a good day.
Thank you.